It's 23rd of November today, and I've got hopefully an interesting agenda for everyone. Before we start the meeting, I just wanted to talk a little bit about what's happening from my perspective out there in the heat of our communities, and just wanted to start with a quotation that is partly related to Mahatma Gandhi, and he said, "How a society treats its most vulnerable is always the measure of its humanity." And our headlines recently have been including how most deprived populations drive a surge in demand for ambulances, how a lack of foster carers risk children having to go into care homes at enormous cost to councils, that people are dying in ambulances while waiting outside A&Es that are too busy to accommodate them quickly enough, and still issues that black women are 4 times more likely to die in childbirth. And no one with any humanity in them wants to read those headlines, which personally I feel ashamed of, but there is a very stark reality in what is happening in our communities that have got some fundamental upstream causes. And they're policies that drive inequality and deprivation, and poor strategies for workforce capacity, from having absent detail in policies to fund the workforce development for the future in a sustainable way. And if you want to see details of how deprivation and inequalities impacts in our country, you don't need to look any further than the Marmot report of 2010 that describes the actions needed to address the problems we have. Unfortunately, you'll have to see what happens when you don't accept the recommendations made by reading Marmot plus 10, and life expectancy falls and morbidity increases in deprived populations. And when there is still no action and COVID-19 arrives, the consequences stark for all, but most of all for those living with deprivation who've died disproportionately. Our workforce engine is running at full capacity in every part of the system, and putting more fuel in its tank won't make it go faster. The consequences of this are the stories in the press of challenges responding to the needs of our people wanting help, be it in general practice, pharmacies, community services, mental health, public health, ambulances, A&E, maternity services, and on our wards. Working at 120% every day means that people tire, they naturally develop their survival mode, and mistakes and missed opportunities become more frequent in the urge to try and meet the needs of the patients they want to give a good service to, whilst trying to look after themselves. And this is what's called burnout. As always, this demand starts in primary care. It's the place where the vast majority of work is done in healthcare. And we've all seen comments about general practice, be it on the TV, in the papers, or on social media. And it was truly saddening to see how really very hard-working colleagues, friends, partners who hold positions of utmost trust in their communities were undermined and questioned about their motivations and competence. That adds to burnout. Unfortunately, but predictably, it was not long before that demand spread to the rest of the system, and the headlines that we all feel shame for come through. And it's not just in the NHS. Domiciliary care and capacity in our voluntary sector is also affected, with the impact that has on helping people leave hospital in a timely way, to complete their recovery at home, or in not having enough capacity to prevent their admission in the first place. Clinical colleagues are being faced with having to say and hear the word no when help is required. And this is not usually for frivolous reasons, but for issues that can then present real conundrums to professionals, families, and the affected individual. Our teams are then having to also bear the burden of feeling that they've been let down and feel morally injured as a consequence, sometimes publicly shamed. This adds to burnout. For periods of time, short periods of time, and if there's a rest period in sight, this can be managed. In wartime, troops are regularly rotated with periods of R&R to help, but we're about to go into winter when we've had already 5 months of high demand, and uncertainty still remains high despite intense and really careful planning by incredibly cooperative, experienced and committed leaders across all of our sectors. And throughout the country, system leaders are highly aware of this and are doing all they can to try and help staff meet the demands on them. But the most pressing solution to those needs is the capacity that has been long missing, and the calls for more staff in pretty much every sector of health service needs to be answered. Once this pandemic is over, we will still have the challenge of a doubling in expected workload due to our ageing population and the impact of policies driving deprivation and inequality of outcomes. So there can be no excuses in failing to address this at the highest level of our society. Significant pots of non-recurrent monies don't address the upstream issues. Recurrent monies need to fuel the long-term strategies our colleagues need to address the known challenges we face. The capacity of the workforce engine needs to grow sustainably, and policies to address deprivation need to come through urgently. Further dither and delay will only make the position harder to recover, so please let's get capacity done. Locally, we've been doing our best to target prevention work towards those who need it most, and we've been increasing support to double the training numbers in our university, as well as creating apprenticeship academies to offer long-term ideas worthy of national support. And popular sound bites associated with those big numbers of non-recurrent money will not do, nor will exhortations to keep going and do more with what we have. They risk waste, initiativitis that's demoralising to staff wanting to do their best whilst burning them out further. So for those in power at the centre looking for meaningful reasons on which to campaign, please can you find it in your heart to support increased workforce capacity and reducing deprivation? In my humble opinion, there can be no more important issues at the current time. Thank you. So going to the business of our agenda, Jo, do we have any apologies for absence?
The only apologies I had was from Badri.
Thank you. And do we have any declarations of interest, any hospitality or gifts over and above those declarations already made? Fanwell?
Yes, Mark. On item number 8 of the agenda on the Aging Well Transforming Community Services, the Ipswich and Suffolk Council for Racial Equality did a piece of work to build some understanding of the needs of people from minority ethnic communities on that, which helped to inform the framework. Okay, thank you. I think it's still perfectly appropriate for you to be in the conversation, Vanwell. Thank you. Okay, and the minutes of the previous meeting, which was held on the 28th of September, are people happy to accept that as a true record? Yeah, I see lots of nods. And going to the matters arising, the action log, there's one action on there for January next year, and all others are closed, in which case, can we move into the general update? Ed.
Thank you, Mark, and thank you for such an eloquent and thoughtful introduction to this meeting. I think that was superb. So just a couple of things from me. Locally, Ipswich in recent weeks had the highest COVID infection rate in the country. So we've been very much in the spotlight there. We're now in an enhanced recovery area where we're getting some additional support from national teams. But the really excellent news is that the rate is starting to fall, and that the COVID booster effort in Ipswich and East Suffolk is absolutely superb. So we've delivered over 72% of the boosters to the cohort that's open, and we're going at a very, very fast rate and huge volumes we're getting through, which is a great tribute to everyone involved. In a similar fashion, Ipswich and East is the highest performing CCG in the East of England on flu vaccination, and will be one of the highest nationally, if not the highest, given that the East of England is leading the way. So thank you again to everyone involved in that vaccination campaign. There's a lot of work being done on the vaccination of children and 12 to 15-year-olds, and Nick Hume, is currently on secondment from his role as Chief Executive at ESNEFT and is leading the work nationally on that. And Neil Maloney is currently acting up as Acting Chief Executive at ESNEFT and doing an excellent job. So I just wanted to recognise both Nick and Neil's contribution there. In terms of elective care, we continue the hard work and the progress. The Health Service Journal ranked us, I think, as 4th best system nationally on elective procedures and 3rd around outpatients. So I think that's a reflection of all the hard work and coordination and progress we're seeing there. On urgent and emergency care, which is the 3rd kind of big area of work we're focusing on. We've got a winter plan later on the agenda, so we'll talk about that later with Paul. And then finally, the 4th big area alongside vaccination, elective recovery, urgent emergency care and service resilience is transition. And we are, I think, the only green rated system in the east of England for our transition works, being led through Amanda and Lizzie Maplebeck. So thank you to both of them. And we're now in a phase where we'll start making all of the board appointments to the Integrated Care Board, which will start in April. So a lot still to do, but we're in a very, very strong position. Thank you to everyone's hard work. So that would be my introduction, Mark. Thank you.
Thank you, Ed. And any questions for Ed on all of that? As you say, there is an enormous amount going on to try and keep the show on the road. So we've come to the patient story time, but we are a bit ahead. I'm not sure that we've got Hayley on the call yet. So would it be appropriate to go straight into item 7? So Maddie and Dean, I think.
It's going to be Dean and Louise who've been leading all of the work that are going to make the presentation. Thank you.
Yes, I'll quickly start and then hand over to Louise. Probably start with a quote, and it comes from probably the founder of modern medicine, Hippocrates, and it talks about wherever the art of medicine is loved, there is also a love of humanity, and that is the key to personalized care. Apart from the fact that it saves money, engages communities, does all the upstream stuff that Mark sort of alluded to earlier. We've taken the strategy through all of the required channels sort of up till now, and we've had sort of really good co-produced sort of critical feedback, which we've woven into the document. The challenge, as again Mark started with earlier, is the 5,000 to 6,000 less GPs that we have, the massive challenges exposed by COVID. And what personalized care tries to do from its founding in the 1970s is to get our communities, our vulnerable populations and individuals engaged back with their care and their pathways. We're all aware of the 6 pillars of personalized care, and although it's fairly a short strategy, in spite of its content, it's going to be asking quite a lot of all of the system partners, from finance to contracts, and essentially it's a change in culture. We all know what personalized care is because we deliver it in fits and starts to certain sort of individuals, certain members of our community. But what this strategy is asking is for a wholesale change in culture. So although the words, and I assume everybody have read them, are important, the how we do things is also sort of critically important. So again, less GPs, a more multidisciplinary workforce, asking for an integration of how system partners work together to develop holistic care for communities and individuals. That's going to be the big ask. So we present this to you today, and I'll hand over to Louise, who will do the strategic and operational bit of the strategy.
Thanks, Dean. Good morning, everyone. As many of you know, we've been drafting the ICS strategy over the last few months, which we have and are still presenting at different audiences and forums, and including patients, because it's really important to us to listen to everyone's opinions and really co-produce this strategy. So I appreciate, because we've been to so many forums, that you've heard the presentation a few times now. So I'm going to take it that that draft strategy has been read. So with this in mind, I thought I'd present what the strategy will mean for us within Ipswich and East Suffolk, and how we will develop it further and take it forward over the forthcoming months and years. So unfortunately, we haven't heard Hayley's presentation yet, but what you'll hear from Hayley is, without really knowing the official title of personalised care, she and others have been using that personalised care approach through the case study today. She's given Lorraine a personalised care support plan, an opportunity for that shared decision making about what matters to her. And by planning to give her a personalised budget to get a fridge and to lose weight and think about her well-being, has absolutely been life-changing for her. And she now feels that people are really listening to her. It was also pleasing when you hear it that actually there was a real MDT approach within the integrated neighbourhood team to support Lorraine further by working with primary care, by working with the voluntary sector organisations, adult social care, housing. And for me, this makes Lorraine not a statistic, but actually Lorraine from Felixstowe, which really is that personal touch. So the terms of reference for us as an Ipswich and East Suffolk Alliance have now been drafted, and this is being presented to our work stream in December for ratification and approval. We have shared both our governance structure, our terms of reference, and our charter with our colleagues from North East Essex and West Suffolk to try and have a real joined up approach. And our programmes of work have also been strengthened, particularly over the last quarter. We'll now be launching a new personalised care maternity programme in January, working alongside Home Start and closely working with our maternity transformation colleagues. It's really interesting to hear Mark talking about that stark statistic of 4 times Black, Asian and minority ethnic women dying in childbirth. So this is part of this. This is that priority. This will see 2 care coordinators working with extremely vulnerable ladies who've given birth and support them up to 6 months post-birth. It will be giving them that personalised care support plan linked with social prescribing, as well as health coaching, educational sessions around smoking cessation, minor illness, educational talks, diet, cooking classes within our new community hub at Witton, and exercise classes such as buggy walks within the local parks and opportunities to use the local allotments. So we've been working with Ipswich Borough Council on that. So further personalised care programmes of work will include a virtual primary care personalised care hub supporting our top 5% complex patients, personalised care for high intensity users within the community, and supporting patients on the elective care waiting list, as well as supporting patients through their stay within Ipswich Hospital, from the emergency assessment units through to discharge on our Welcome Home service. This will see patients supported back into their community with wraparound service from social prescribing, incorporating volunteers and the voluntary sector. So it's worth noting that we've started to procure or re-procure our Connect for Health social prescribing programme. The programme and the procurement will commence in January, with the process finishing at the end of March, with the new contract commencing in July. We've learned a lot over the last 3 years, and we'll obviously incorporate that learning alongside some new outcomes. in that paperwork. And the model will see a 4-layer approach, including volunteers, those link workers, our Borough and District Council engagement officers, and health and wellbeing coaches. So enable us to achieve this radical change, we are working with the Workforce Hub to ensure we are supporting our workforce to gain an understanding and a confidence in delivering that personalised care approach. We've commissioned Judy Oliver to apply to be a fully accredited and certified trainer in personalised care. And this will be a bespoke package for Ipswich and East Suffolk, and will link our one team ethos and leadership training and the knowledge of personalised care. And we're hoping that that first cohort will run in January, with working alongside our maternity colleagues and the programme. So the next key steps required to mobilise the strategy is for final sign-off to the ICS board in December. And following that sign-off, we will develop and deliver a communications campaign for all system partners, workforce and public to raise awareness and understanding of personalised care, including our strategy, aims and objectives, and delivering the benefits it will bring to local communities and people. Any questions?
I'll just end, I'll just probably end sort of quickly sort of with one quote. This is going to be ambitious. It's going to be whole population, whole system. It's going to ask for cultural change. It's going to ask for a financial strategy that backs sort of personalization. And the reason it's going to do that, it's because the system is under so much pressure, and the outcomes are not where we want them. So again, ending with a quote from Marian Wright Edelman, who was pre-war, who recognized that this integration, this co-production, this way of engaging and empowering patients and communities is the way to go. And it's a question and a challenge. And the question is not whether we can do this, but whether we can afford not to. So I think it's critically important that we understand that although it's a strategy on a few sides of A4, the ask of the system will be challenging and wide-ranging.
Thank you, Dean. Thank you, Louise. Maddie.
Thank you, Mark. So I just wanted to thank Dean and Louise for their immense leadership for this programme, and to just thank Louise again for bringing it to life, because in some forums I've presented it in terms of the aims and the outcomes and the programmes of work. But I think what you've heard from Louise is what this really means for individuals. And the maternity programme, I think in particular, was such an important one to highlight of the difference that this can truly make to the outcomes that we're seeking to achieve. And just to note as well how the social prescribing, which is one of the 6 programmes of work, what a journey we have been through. And I think it's really important to note the learning approach. We describe the ICS as having a learning culture, and that's what you see in the development of our social prescribing programme. It's been ongoing learning, but in a very positive way from scratch. And thirdly, just to reiterate the huge importance of the involving all of our workforce in this change. It is a culture change as well as a change to how we plan through contracts, through financing, and our programmes of work. But that will all rely on a cultural change. So I just wanted to really emphasise that too. So thank you again to Dean and Louise, not only from Ipswich and East, but I think.
Thanks, Maddie. I'm going to ask Fanwell to come in, and then what I suggest is before we make our decision, we actually hear from Hayley, who has now arrived, and welcome, Hayley, so that we can hear how much more this story brings this personalised care agenda to life before then making the decision, if that's okay. So Fanwell first.
Thank you, Mark, and thank you, Louise and Dean, for that comprehensive presentation. I think, this really lies at the core of what is going to drive change for our communities, particularly in terms of empowering people to make decisions on the issues that inflict them. Sometimes when we talk to people in communities, they really value the issue of personalized budgets, particularly because it allows them to purchase the kind of support they need. But in some instances, people find themselves with the challenge that, they know, especially when you're talking about things like religious or culturally appropriate support, they know what they need, but sometimes it presently doesn't exist in the market. So are there plans within this program to ensure that even when we give people those, personalized budgets, that when the service doesn't exist, there will be support in terms of, developing those services in the market so that people can then go in and purchase them?
Well, I can take that. The first thing to say is that yes, personalized budgets are important, but what probably more important, and it speaks to the culture change bit that we'll be introducing to this. It's no good to give somebody a budget or a resource for a service that doesn't exist. It's no good to create the service that you think they want and then give them the personalized budget to purchase that service. What is absolutely critical is that we go into a full, true co-production with our communities, with those places of inequalities, and we get them involved in the full PDSA sort of cycle. So we have a foundation for that in social prescribing, in that at any point within social prescribing on our board, we will have 2 or 3 very critical patient representatives. We will bring in people from a wide range of inequalities, not to be consumers of what we do, but to be producers of what we do. So yes, the communities, diversity, sort of equity, sort of communities are now well known because of the 2-3 years of foundational work that we do. So it's not going to be a case of just going, okay, what do you need? When do you need it? How much does it cost? It's going to be a case of what do you need? How can you help us co-produce it? And the reason that is critically important is that, quite simply, it delivers better outcomes for less money. And if you go by that principle of working side by side, not only with those that suffer from the outcomes, but with system partners, then you get decent, sustainable, scalable sort of results. So yes, it's not going to be a case of just handing out money. That is an important but a small part of what personalization is.
Thank you, Dean. And to help put this into personal context, I'm really pleased to welcome Hayley to our governing body, who works as a social prescribing expert and here to tell a story about Lorraine from Felixstowe, who is unfortunately unable to accompany you today, I understand. But Hayley, welcome, and we look forward to hearing your story.
Thank you. Yes, Lorraine was going to join us today, but unfortunately she's unwell. She was going to speak from her own voice, but she has passed on her experience and her thoughts, and I've just put them into a bit of an overview of the work that has been carried out so far. The work is still ongoing with Lorraine. We're not done yet. There's still a way to go, but I just wanted to give you an idea of the picture of how she's been supported so far and by who and which direction we're going in. And also just to point out that actually Lorraine is not an isolated case. We have many people that we're working with in this way, and we're finding it to be really useful. So I'll just give you an idea about Lorraine's story anyway. So Lorraine is 67 and lives in a flat with her brother. She has mobility issues as a result of her weight and the impact this has on her legs. She's been diagnosed with cellulitis and edema and has been in hospital with issues relating to these. Most recently, she was admitted to hospital due to widespread infection in her legs. There, she was referred to Connect for Health as part of the plan to discharge her, as the hospital had some concerns of self-neglect and neglect in the home. Lorraine met with Alexis, the community connector who visited her on the ward. Lorraine spoke of her need to move as her current accommodation was no longer suitable for her needs. So she currently lives in a first floor flat, and access is via concrete stairs and no lift, which of course is problematic for Lorraine. Lorraine also noted about feeling very isolated as a result of being unable to leave her flat. Alexis supported Lorraine to complete an application for Gateway to Home Choice to acquire more suitable accommodation and referred her to a befriending service. Lorraine also disclosed that her home is in dire need of declutter and deep cleaning due to years of hoarding and self-neglect, and agreed to a referral to Lofty Heights. Lofty Heights visited the property and noted concerns for welfare as a result of the condition of it. Alexis consulted with MASH and submitted a safeguarding referral, and she attempted to advocate with the housing provider Orbit and eventually managed to speak with them about the welfare concerns and the importance of placing Lorraine and her brother somewhere more suitable. Orbit advised they no longer manage moves but would be willing to support her application of priority banding for housing. Upon discharge from hospital, Lorraine was transferred over to the Felixstowe Connect for Health service to pick up where Alexis had left off. Lorraine was transferred over to myself and was added to the surgery's MDT meeting list as well, where her care and support can be discussed by other professionals to ensure that the right support is in place. I made initial contact with Lorraine, and together we set to work to develop a personalised care support plan that focuses on what matters to her and prioritise her needs. It was clear that moving to a more suitable ground floor property was of paramount importance to her, as this will give her some freedom. It will improve her well-being, and she can take steps to improve her mobility, which will improve her weight and slow down or even stop the deterioration of her health conditions. Lorraine's GP had written a letter to support her priority housing need request, which was sent over to Gateway to Home Choice, and we're currently awaiting the outcome of her application. In the meantime, I have liaised with social care and arranged for Lofty Heights to provide a quote for works to be undertaken in her property to make it safer. This quote has now been passed to social care, going to arrange funding to carry out the work. Lorraine has felt that her needs were not being met by the services involved previously, most notably her own housing officer, who tried to just signpost her to mental health, when in fact what Lorraine needed was for someone to listen, understand and develop the right plan of support in order for her to move forward. With social prescribing involvement, they were able to identify, liaise and coordinate the appropriate services to ensure that that ring of support was placed around Lorraine in order to fulfil her needs. Lorraine's case is ongoing, but she now receives calls from a befriender once a week to chat about everything and nothing. But this is helping her feel less isolated and just has someone to talk to. Her housing application is under consideration, and we're hopeful that with the support of other services, including social care, GP, community healthcare teams, social prescribing and home group, she will be placed as a priority banding in order to get her moved into more suitable accommodation on a ground floor. In the meantime, once funding is in place, Lofty Heights are going to declutter and deep clean Lorraine's home to reduce the health and safety and fire risks and help improve Lorraine's home environment. I'm in the process of completing applications for funding to get her a better chair to sit in and bed to sleep in, and even a new fridge. Currently, she's using a freezer at the moment with a broken door. Although, also through the planned use of Lorraine's personalised budget, we shall together look into accessing services in the community that can help Lorraine to focus on her plan to lose weight and increase physical activity by linking her into slimming groups and exercise clubs with the plan to improve her outcomes and reduce further hospital admissions. The impact of social prescribing has been acting as a coordinator to bring together the various services needed to ensure that the right support is in place for this individual, placing her at the centre using the personalised care support plan that has been co-produced between them, putting that ring of support in place, being that main contact and everyone taking ownership for their part, has helped ensure that no stone is left unturned.
Thank you, Hayley. A great story of how, at its best, the way the system can work and can respond. and can I just say thank you to you and to particularly to Lorraine. Please pass on our thanks for her willingness to share her story in such detail, because it really does help transform words of a strategy on pages into something that feels real and tangible in what we want to try and achieve. So thank you for that. We've got a chance for questions from the governing body members. If anyone has anything that they want to observe or raise. Stunned into silence, which is so unusual. Maddie.
Thanks, Hayley, and thank you for all that you're doing. So my question would be, is there anything that you think could have been even more helpful? What is there anything else that we could do that would support you or support Lorraine in her journey?
I think at the moment, I think just by having everybody involved, I think just keeping those lines of communication has been really key. I think the MDT meetings has been massively helpful in this case, because we've all had the opportunity to sit around and be able to take away our own actions in order to support this lady. So at the moment, I mean, like I say, the work is ongoing. Housing is taking a long time, but then housing is the main obstacle at the moment, I think, for this lady. So I don't think there's an awful lot that can be done there, because I appreciate housing are quite stretched at the moment as it is. So it's just about making sure that we continue to make sure that her pathways are clear and that it's a smooth progression into improving her well-being and improving her situation.
Thank you.
Imran and then Aisha.
Thanks, Hayley. Can I ask a question? Do you, bearing in mind Louise and Dean's earlier presentation, is there a mechanism for you, kind of who's on the ground, sort of, you know, observing what's going on, to raise issues around sort of gaps in provision, or, for example, VCS partners that are struggling to provide and there's a, you know, huge demand for a service? Is there a mechanism for you to raise that so the system can say, okay, we've got a great big gap there, we need to support a provider or commission a service? Is there, do you know of any way to do that, and is that something we need to look at?
I think what's been really helpful is that actually I'm part of the INT core leadership team, and so I'm able to attend INT meetings, and if I identify gaps, then I'm able to bring that forward and maybe see about getting that included into the INT plan, so that it can be raised by various other people around the table to see if we can come up with ways to plug those gaps. And also I'm aware of the community chest that possibly is there that can be accessed to enable to help plug these gaps in the local area as well.
Thanks, Hayley. Aisha.
Thank you, Mark. So my question is for Louise. I think it's a brilliant idea about the care coordinators, and as you know, most of the PCNs have got care coordinators already employed. So going forward, how is the plan to support those particular care coordinators? I know the Personalised Care Plan Academy is offering training, and like Judy is going to offer, but I was hoping about a plan to have some networking locally, and just running a forum for, just like we do for our paramedics and our pharmacists, if we can do something similar for them so they can actually learn from each other and support each other in community. I know they've got a national WhatsApp group which they've joined, but something to do more locally would be really helpful, and to share good stories of support like Hayley shared today, and they can always learn from each other. So is that something you can plan for us, please?
Thank you very much, Aisha. You're absolutely spot on, and it is imperative that we bring these different additional roles together to learn from each other. So we do that with social prescribing. So our Connect for Health social prescribers, we meet every month, and there's peer support, and we bring in our PCN social prescribers into that fold. And it is something that we've been discussing around the care coordinators, because we offer training for all of them, Aisha. So I think you're absolutely right. It's imperative that we bring it into that model, that 4-layered model that I probably just touched on in my presentation around the procurement of social prescribing. So yeah, absolutely.
And I would say that the role of care coordination going forward is going to be really important. And the more proactive we can make it through using good linked data sets, as well as the intelligence on the ground from people like Hayley and her colleagues in the Connect space, I think we can really make a difference. For those who aren't familiar with co-production, I see co-production as a meeting of minds to develop the most appropriate solution to a problem. Rather than necessarily saying that it saves money, I would say it drives value, which is even more important, because if it costs a bit more money to get better value, it's better to spend that money well. And the paper and what we've been hearing from Hayley and others in the discussion afterwards is that that it's a really heartening and welcome approach, and it's the right thing to do, not just because of the pressure we're facing, but the pressure we'll be facing in the future. It's the right thing to do. Using co-production, committing to continuous quality improvement, broadening the approach that connects people back into their communities and keeps them there, using training. You know, the expectation that people will change their culture without training and understanding, it's wrong. It won't happen. We need to invest in that training, and it will drive culture change. It will drive an expectation across the system. And most importantly, I think what we will see is trust build. If we've got the right culture, and we're doing the right thing, it should help to build trust in deploying the resources at the point at which it's actually needed without having to ask permission, because you're doing the right thing. And I think this is what a personalised care strategy is saying that it will do. And we've heard that it's possible to make it happen. Louise.
Thanks, Mark. I just wanted to thank Hayley for this morning and giving her time up. I know when you're busy, and I know this wasn't easy for you, so thank you very much. And your fearless speaking worked. Judy would be proud of you.
Thank you.
Indeed. Lots of thanks from all of the governing body members, Hayley, for your presentation and your ability to answer those questions fearlessly.
Thanks very much.
Thank you. So we also have to approve that strategy, and we've come to the point where I'm going to ask, are we going to approve the strategy? Does anyone not want to approve the strategy? Okay, approved it is. So thank you again, Hayley, for helping get that approval through.
Thank you. I shall leave now. Thank you all.
All right.
Thank you, everybody.
So, thank you for that, Louise and Dean. We're going to move into the Ageing Well Transforming Community Services paper now. Richard, over to you.
Thank you, Chair. I'm looking on the other screen. I'm not staring into space, just to forewarn. So there's a short paper in the pack which outlines our proposals in terms of a new pot of money that has come our way that we're keen to utilise. So just to take you briefly through the paper, background is that all integrated care systems like Suffolk and North East Essex have been allocated a specific fund called Ageing Well, which effectively is around continuing to transform community services, effectively to boost out of hospital-based care. You'll see at section 1.1 some of the specifics that the long-term NHS plan expects all areas to try and achieve. And this very much fits with Ipswich and East Suffolk's direction of developing our integrated health and social care teams at place level in our localities, and the ongoing development of our REACT admission avoidance and discharge support services. The Ageing Well National Programme, section 1.2, is split into 3 subcomponents. So the first, which sounds slightly odd, anticipatory care. Effectively, how do we locally identify those that are most vulnerable, most in need, and start to proactively support them so that they don't need to necessarily going as an emergency episode into our acute hospitals. When they do, number 2, that we respond within 2 hours of the call from the hospital to actually support them either as an admission avoidance, so avoiding acute admission, or supporting them back home or in their place of residence. And then importantly, the third part is enhanced health in care homes. As we know, this has been a very long established piece of work within Ipswich and East Suffolk. So a lot of this is building on the brilliant work that's happened within our local patch. So all of those 3 elements come together as the Ageing Well programme. In 21-22, we've been given a funding allocation each integrated care system. You'll see that as section 1.3. It breaks down into 2 parts. The bulk of it is called community services allocation. So effectively, as I've described, enhancing against those 3 subcomponent parts. And then there's a small round for system leadership prep. So effectively putting some of the clinical leadership around. And I'm pleased that Dr. Selina Lim is our overall clinical lead for this programme, supported by a range of other clinicians, both primary, secondary and professionals, particularly our social care leads. The allocation for Ipswich and East Suffolk, you'll see within the table, is just shy of £1 million in terms of the community service allocation and just shy of 46 on that system leadership pot. I suppose the most important table then is just under section 1.3 is then, so how are we proposing to utilise that funding? I think it's important to say as it stands, that firstly, this came in 2 allocations, as is always the way at the moment with the budget for this year, first 6 months and second 6 months. So we've only just been given the second 6 months, hence why we're only bringing this now in terms of a complete picture on how we propose to utilise the funding. We are expecting the funding to be recurrent, but it's not an absolute 100% foolproof. We haven't had it in absolute red writing from NHS England, but we've been told that given the direction of travel is increased investment in community services, to assume that this money is recurrent in the nature of how we apply it effectively. So the breakdown, just a couple I'll highlight rather than going through them all. I know Clinical Executive has also been through the detailed paper. Is a significant slug, 185, is for what's called remote monitoring, optimising virtual ward. What that means in practice is trying to provide as much wraparound support to an individual to enable them to stay in their place of residence, their home, rather than either going into a bed-based community provision or indeed even worse, potentially staying in hospital when they're medically fit and could go. The second one to pick out is continuing to grow and enhance our discharge to assess model. So effectively that's how again do we build further support out in the community to support those to get out of hospital and back home as soon as possible. So we're in the process of changing our current discharge model from being very central with a core team within Ipswich out into 3 hubs, one of which will be Ipswich. So there's an additional investment of £752,000 there, just towards the middle of the table, to effectively future-proof that model as part of it. And then the final one to pick out is a late entry, but an important one, is the Integrated Neighbourhood Team Ageing Well Coordinator posts. And I think Maddie and I, and hopefully many of you, are excited by this development. So linked to that anticipatory care, each of our integrated neighbourhood teams will have an Ageing Well coordinator who will be very much rolling their sleeves up and supporting that locality team in identifying and coordinating the support, particularly to those frail elders within our local community who might need that kind of proactive support offer. So overall, and Jane will be pleased to see, we've got a surplus. So this year we've got just shy of £500,000 because of the late nature of the allocation and the ability to spend this in an appropriate way. We have still got a shortfall in terms of actually allocated schemes against this. But actually, when you roll this forward into the next financial year, going back to my point that we've been told to assume this is recurrent, the majority of that money is expected then to be spent once recruitment is underway. So just shy of 170,000. So I'll pause there, Mark. Happy to take any fierce questions that come my way, or open to others if they want to chip in as well.
Thank you, Richard. And all popping hands up here. Come on then, Ed. First fierce question.
Yes, I might disappoint you. I mean, I think this is brilliant, and I think Ipswich sets the standard around place-based integration. It's really brilliant. My question was around children. So a lot of this seems to be angled or positioned towards older people, which is perfectly appropriate. But is there also work around kind of supporting children additionally from a community services perspective?
So tangentially, this funding is not aimed towards children, but I will absolutely double check that. It is predominantly towards adults and particularly frail elder. Happy to talk in a bit more detail about the children's work. So we've done a review with an organisation called Rethink, looking at our children's community services, and there's a whole heap of recommendations that have come out of that work, both practical and strategic. In terms of the tactical, operational, later on, I think in the integrated performance report, there's a couple of headlines in there around additional investment that we've agreed, I think through the clinical execs last month actually, in some of the paediatric sensory OT provision, also in relation to another number of services that we feel collectively are underdeveloped. That came out of the Rethink report. The second thing is there's work underway between both of our physical acute trusts with the community service that they host, West Suffolk Foundation Trust hosts it, about how they can further integrate the acute and community nursing offer. So it's more of a streamlined integrated service, and that work is underway, led by our nursing leads within our 2 acute hospitals. And then just finally on the strategic, one of the big things that came out of this piece of work was we need a strategic framework, an overview of what's the plan longer term for children's across Suffolk. So we're about to commence a process in January, short piece of work for about 2.5 months, to develop a short children's strategic framework, including Waveney, so it'll be county-wide, which will set the context then of what our programmes of work should be over the next 3 years. That's a jointly sponsored piece of work with Norfolk and Waveney ICS and Suffolk County Council. So there's operational and strategic work happening in that children's community space at the moment.
Thank you. Thanks, Richard, for that. Maddie and then Fanwell.
Thank you. So this, I think, is an absolute fit with our overarching alliance strategy. This builds on the very best of what we have been doing. It fills some gaps, and it is of a medium recurrent nature, I think, which is really critical. And I just wanted then to touch on the element of it which relates to care coordination and to link with the previous presentation. We have now, with this, a unique opportunity to invest in care coordination within the integrated neighbourhood team, and to link that through the work that's being done on population health management, of understanding the need, the multidisciplinary team to provide the support and coordination with that, which is we are investing in primary care, which Aisha mentioned, so that there is a direct line of sight there and a direct line of support, and also through with the social prescribing work that Louise described earlier. So this funding provides us a unique opportunity to build the next steps of our strategy and to deliver the very personalised care for frail elders within our community. So I am 100% supportive of it. Thank you.
Thank you, Maddie. Manuel.
Thank you, and thank you, Richard. So firstly, I just want to commend, the work that is being done, particularly by the Ipswich and East, the Frailty Steering Board, sort of, trying to reach out and get a bit more understanding and also building on this. Talking to people in the community, I mean, one of the things that came out very clearly was the fact that, when it comes to the language that we use, things like frailty, there are clinical definitions of what that is. And more often you find that those definitions they do not resonate with people in the community in the way that, we expect them to. So for people to come forward and access the kind of services that we're developing, they need to have a better understanding of what it is that we are, trying to say. And, recommendations have been made to the board, and we're going to be talking to them moving forward. But we need to try and simplify the language for our communities so that they can see themselves as the people that we're trying to target. But there is a paper that we did, and I would probably encourage that it be circulated to the board as well. After the meeting with the notes, and they are very simple things that people came forward to say when we talk about the elderly. People were saying, all the aches and pains are just part of normal getting old, and you don't seek help or you don't go and bother your GPs or your doctors because of simple things like that. So on one side, we're creating services that we're saying we want people to come forward. On the other, people are saying, actually, this is just part of normal growing old, and I'm not going to seek help around that. So as we go out into the communities and talk about, this piece of work, I think we need to bring our communities on board and actually make them realize that they are part of what we're trying to. Otherwise, there will be a disconnect between, the services and what the communities are expecting.
Thank you, Fanuel. I think it's really important that as welcome as this funding is and where it is being placed, that we never lose sight of the prevention. And you think, well, can you prevent people getting older? No, of course you can't, but you can prevent people becoming less able as they get older. And there are methods of prevention that can work. We know that, and we also know that deprivation drivers in older populations have significant impact. So there are, that's why we've had triple lock on pensions for so long, is to ensure that our older population try to have less deprivation than they may otherwise have had. And that pillar one in the frailty strategy, and I totally get what you're saying, Fanuel, about the language, but nevertheless, what we want to achieve through pillar one is prevention, and we've got the WHO ICOPE project starting to come into fruition now, and a real opportunity for us to learn more about what prevention can offer for people as they get older and what is going to be required. So hopefully we'll be able to give much more informed decision making for the future around frailty and prevention, as much as the absolute requirement that we manage acute needs as much as possible at the point of care, not having to take people away from their homes and their families. So we've heard a huge amount of support. I haven't heard anyone say no. So with that, and the bell ringing about prevention as well in our ear, I'm suggesting that we approve that investment and look forward to maybe hearing more about how it's impacting in the future, maybe March time, if we can hear any of the outputs. That would be really good. Okay, thank you. So shall we move on to procurement update? And Paul?
Thank you, Chair. I'll be fairly brief. I'll take the paper as read. The paper highlights probably a couple of areas. First one being pathology. We are currently discussing and talking to our current providers in terms of timelines to make sure it doesn't disrupt local plans, and in particular around the issue of formal collaboration moving forward. But essentially, timelines and processes has been worked through and will be in the process of being agreed. The main probably part of the paper sort of focus on the mental health agenda. And as you'll remember, as part of previous conversation, we took a double-pronged approach to managing future services, particularly within SFT. One being an assurance process, which focuses on crises, children and young people, community and learning disability. That process is ongoing. We were in receipt of the workbooks, which are essentially the evidence that we sift through and go through to assure ourselves that services are being provided as they should. Unfortunately, that process was slightly interrupted by a CQC visit, which meant we had to do a slight pause in this process. Having said that, we had some ongoing conversation and decided to forge ahead through a much more collaborative approach. So instead of having essentially a backward and forward workbook approach, very much meeting, collaborative working discussions, meetings to capture all the relevant informations, which essentially makes sure that puts us back on track. So expected that to conclude ready for board in January next year. So again, some good progress on that. In terms of the other couple of elements, which is the Community Connect and the Daytime Wellbeing Hub process, which is for services for patients not requiring sort of secondary care services. I'm pleased to say that went out to market on Friday as planned. So again, we are planning to bring that back to board in March 22. So again, some good progress against originally described plans. And I'll stop there. Happy to answer any questions.
Thanks, Paul. Any questions for Paul? In which case we'll receive and note that summary. Thank you, Paul, to you and the team for that. So we'll move on to the SEND annual report. Lisa.
Thank you. So this is really a summary, an abridged version of the SEND annual report, just focusing on some of the key priorities that we've took forward this year and looking forward to next year. So under the strategic planning, the first bullet point, I think I just really want to highlight to the board as being a massive enabler of the work that we've been able to take forward. So we have established and recruited our DCO team, and we've really invested in both our children and young people quality team, but also our DCO team. We now have Deputy DCO in place, as well as the DCO across Suffolk and North East Essex. And that has really meant that we've been able to focus on the joint working with Suffolk County Council for this report, but also some of the quality improvement work that we wanted to do within the SEND programme. So it's been incredibly helpful, and actually has our establishment and our team structure has been acknowledged by the National SEND team as a really exemplar team structure to have, and we've shared it across the east of England. So one of the things that we wanted to make sure that we did over the last year was benchmarking ourselves again against health statutory duties in the SEND Code of Practice and the Children and Families Act. So we've done a lot of work, and that's helped us to take forward the QI work that we wanted to do to make sure that we were going really above and beyond our statutory duties, and we're really focusing on the work that we needed to do to make sure that children and young people who have education and health care plans have quality plans, particularly from the health aspect. So yeah, lots of work around that benchmarking activity. I'll go on to the second slide, which goes into a little more detail in the statutory duties. So by increasing our team, it's meant that we have been able to be a real presence at the Education, Health and Care Assessment panel, which is where the decisions are made around individuals' education, health and care plans. And previously we hadn't been able to be always and consistently present, and that it's a really important part that health is present and inputting into those education, health and care plans, because we know if a child or young person doesn't get the right EHCP from the outset, that leads to some significant challenges for that family. So I'm really pleased that we're now able to be a really important partner in that. As well, the tribunal process, so it's really clear in the Code of Practice health's involvement and how health needs to work in partnership with the tribunal process and learning from tribunals and the mediation process. So again, the increase in establishment and team has allowed us to be able to do that and to be able to sign off the health elements of the EHCPs. Going on to the next slide. So we've done a lot of quality improvement work around the SEND programme over the last year, making sure that there is really strong multi-agency audit of the education, health and care plans, checking the advice, making sure that we are giving really good advice, support and training from health to our family services team within Suffolk County Council, and supporting and training our NHS providers on plan writing and how to write a good health statement for the EHCP. So there's been lots of work around that. I think the other piece that I really want to pull out that we've been developing over the last year is the impact and outcomes framework. We, for the SEND programme, we've always been very focused on experience and feedback, which is absolutely right, and actually how a child and their family feel that the care that they get from all services has helped them to achieve their potential is one of the most important metrics. But actually, we have never had a really strong outcomes framework, so we've really advanced that this year. It's still it's not quite there. We'll be looking to share that next year, but we've really made some great progress on that. And I think we've continued to see, particularly with the joint appointment now of my Deputy Director of Nursing in CYP, some improved joint working across health, education and care for children. So the next year, we obviously have our SEND strategy, which you've all been cited on. So we need to continue to implement that in 21-20 to 23. We have, as you will be aware, we had an independent review, peer review by Lincolnshire County Council colleagues, and we will be supporting and working with Suffolk County Council to implement that action plan. We continue to make sure that our governance, structure and accountabilities are in line with the Code of Practice, and there is some continued work that we want to do around that. We will be preparing for re-inspection. We know that during the pandemic there was a pause on inspection, but we suspect that within the next year we will be visited again and our services judged again by Ofsted and the CQC. And we absolutely want to continue the work on the co-production strategy. So I'll leave it there, but happy to take any questions. Thank you.
Thank you, Lisa. I'll allow people to think of their questions. Ed.
Yeah, thanks, Lisa. It's brilliant. You know, I think we've become such a stronger partner within the SEND space, and so thank you for your leadership and your team too. My kind of more of a comment or an observation. Suffolk Parent Care Network, obviously stepping back, they held up the mirror, didn't they, to the statutory sector, and we got a lot of feedback around lived experience. I'm just a little worried that we don't have that now to the same extent. Maybe we do, but I just wanted your views about how we're listening to the families in Suffolk to make sure we're in touch with what's actually happening.
Yeah, I completely agree with you, Ed. I think the experience that Suffolk Parent Care Network brought to us consistently was incredibly helpful, and we always wanted to extend that so that we weren't just listening to Suffolk Parent Care Network, because they're incredibly helpful, but actually not all families with children, young people with SEND or the children themselves were members of SPCN. So it was always important to extend that. There is a group that has formed that is looking at re-establishing our Suffolk Parent Carer Forum, because actually we do have to, it is part of the statutory regulation that sits around SEND that means that you do have to have a Suffolk Parent Carer Forum. So there is some joint work happening to re-establish that. So that would be really good. But I think we must continue to make sure that the voice of the child and young person is in there as well. So actually taking the strengths that we had from SPCN, but making it even better, I think is where we really want to go.
So, Graham and then Richard.
Thanks, Mark. Lisa, I've sort of been watching or looking over SEND for quite a while now, and this paper is sort of listed as an annual report, isn't it? And it's more, it's not sort of like listing out what we've achieved in the year. It's more of like a complete overhaul of the whole system, which I thought is needed for quite some time now. And the independent review that you mentioned, it was quite damning in terms of its content and the sort of recommendations it made. And it was actually basically saying that there was no system in place to sort of oversee SEND. So, I mean, I really welcome the paper and the work that you're doing. But I suppose my question is really, where was the oversight board or the committee that should have been in place to oversee this? And, you know, how are we going to strengthen that sort of leadership and oversight of this so that we don't sort of get into this mess going forward?
Yes, so the review that Lincolnshire County Council did for the SEND programme focused on some very specific areas within Suffolk County Council's delivery around their family services, and it was one of the triggers for the review was actually through the SEND board was from families. Families were voicing their concerns around the experiences that they were getting through the specialist education placement process and from family services. So although it's been a difficult time for us jointly as the SEND programme team, I really applaud Suffolk County Council for taking that step. They could have done an internal review, but actually they said we want to have an independent peer review, and they published that review. I think there's been a lot of internal questions. You know, we've reflected and asked ourselves a lot around what do we need to do to put into place to make sure that it goes back to Ed's question, how do we make sure that the voice and the family experience is more prominent, and we use it more as a trigger to alert us to when things are wrong? I suspect we weren't quick enough at doing that, if I'm honest with you. But it's not been the SEND programme board's probably finest moment to receive the outcomes of the action plan, and certainly for children and young people and their families, you know, it's really highlighted some of the difficulties that they face. But I do applaud Suffolk County Council for doing that and taking that step forward.
Yeah. I mean, just following on from that, then, Lisa, I mean, how do we actually measure the outcomes or progress of all the patients, I suppose?
Yeah, well, and that's part of this outcomes framework, Graham. So there's a number of ways. So the governance of the SEND programme has priority work streams underneath. So we have an education, health and care plan work stream. We have a transitions work stream. We have a number of work streams that are focusing on the weaknesses that we know we have within the SEND programme board. There is then something about, on an individual level, how do we know that the education, health and care plan that each child and young person has is delivering the outcomes that is required. There's that individual level. It's about measuring outcomes on many levels, really. And then there are the outcomes of the services we commission. How do we know? So for example, Richard's team have been doing masses of work around our neurodevelopmental pathways. So how do we know that those services are delivering the outcomes for children and young people? And all that is part of the draft outcomes framework that our teams are working on.
Okay. Yeah, thanks, Lisa. I wasn't being critical. I was just trying to,
it's fine.
push it forward so we get
a
tighter grip on the service. So thanks very much.
Richard?
Actually, Lisa's just segued to what I was going to briefly give an update on the neuro work. So there was a number of areas in the SEND report where we needed to take action. So that was speech and language therapies that you remember we agreed over £1 million investment to really boost the workforce, which has actually worked really well. So we're pretty much recruited to all those original roles, but now we've had a bit of a blip with fallback. So there's more work happening there. CAMS, Children Mental Health Services, I think we've talked at length here. It's fair to say there's a lot more to do, but we've now got an agreed future model. We've got the extra investment going in. One of which is the mental health practitioner posts for children that we're hopeful each primary care network will take up the opportunity afforded on that. And the one just briefly I wanted to highlight, and I think we're due to come back, Mark, to the clinical exec in the new year or probably February, is I think this finally I can see light at the end of the tunnel on the neurodevelopmental model. So we're due to soft launch in January, the entirety of the new model, which effectively is comprehensive triage panels of every individual that comes through for assessment. Rather than going into those silos, there'll be one clinical panel of health and care professionals who will be looking at each one and making a decision who the lead professional will be for that young person and their family. We've put additional funding in, as you know, in terms of meeting some of the recovery work we have to do given the increased demand. And also we've just appointed Bernardo's last month to pilot the coordination function. So that's a really good, I think, partnership between our providers in the county council, new voluntary sector partner, NSFT and West Suffolk Hospital. And then finally, we're pretty much now really in the thick of mobilising those voluntary care and social enterprise services that we agreed. So those pre and post diagnosis support offer to young people. So Noise Solution and others that are working with us. So I think in February, subject to fingers crossed the soft launch, after a couple of years of a hard journey, it feels like we're going to be in a place where we've got an entire model now set up and we can start to really monitor, as Lisa said, what's the outcomes we're now achieving for those children and their families.
Thank you, Richard. Lots of threads all starting to be pulled, hopefully. So Lisa, thank you. Thank you to the team. I mean, what we've been hearing, comes back to some really fundamental issues. Self-actualization is the ultimate outcome in Maslow's hierarchy of need. If you can self-actualize, that means children getting the best start in life. And education is an absolute foundation of that. And we've heard that if you don't listen to the lived experience of the services, we're not going to make that progress. There's an old saying that is, if you don't listen to the whispers, you'll be condemned to listen to the screams. And so that part of this programme is so important. And fundamentally, what we've got to do is have the capacity to recognise children with special educational needs and disability. We've got to have the capacity and ability to create good quality plans. And we've got to have a commitment to meet all of those needs and commit to hear about the lived experience of the service if we're going to improve it. And those, I think those four things are the fundamental way in which that combined way of approaching this issue needs to go forward. And I think that's what you've been describing, Lisa. And hopefully we'll be seeing the improvements with the investments that are going in that that will bring improvement about, but it'll be after our time. It'll be into the integrated care board time, but nevertheless, I think it is so fundamentally important. So thank you for all of that. We're going to now move on to the patient and public involvement and experience. Lisa,
thank you.
You're named again.
Well, I know, and it's a great segue again into this, because we've just reflected that listening to families and children and young people is critical. So this is really a paper of two parts. So the first part details our involvement strategy for commissioning activity as we transition into the ICB. We're required to have a strategy in place by March 2022. It's been through all our usual governance routes. So it's been to both clinical executives in Suffolk and to the Operational Executive Committee in North East Essex, and it has been co-produced and aligned with our NHS provider strategies that they have for involvement. So I won't go obviously through it in great detail, but Appendix One really details the 10 guiding principles that we would like to focus on over the next 3 years. So making sure that we are putting the voices of people at the centre of our decision making and governance around commissioning activity, ensuring that we have a really good cycle of engagement, so we're involving people at the start and making sure that we're feeding back to people. I don't think we do that part very well. I think if we, this is our vision. The next piece of work that we need to do is to understand where we are with some of this, but certainly I think we do some elements okay with the cycle of engagement, but I don't think we complete it, and I don't think we do it consistently well. So understanding communities' needs, and then understanding if that change has been made through our commissioning. So again, that complete cycle. And yes, so the strategy is there. There is a 3-year plan. The first year is really focusing on culture and the enablement and how we need to move forward. The second year is focusing on the development of sustainable systems. And then the third year, we've kind of put refresh and take stocks. I think a lot will happen over the next 2 years, that it's almost quite difficult to know what the third year will look like. So we haven't been hugely explicit about the third year, because I think we will need an opportunity. If we become too directive around what 2025 looks like, I think we'll box ourselves into a corner. And actually, I think there's going to be such change next year that by the time we've delivered years 1 and 2, year 3 will need to be evaluation, taking stock and refreshing and looking at where we still need to move. So that's the first part of that. We've had some significant feedback from partners, which has been incredibly helpful, which has meant that we have been much more explicit about how it links or will link to the quality strategy, to the quality planning improvement, the quality planning control and improvement cycle, and how that will all work. The second part of the paper just details the Q1 and Q2 activity that the public and patient involvement team have been doing, and I just want to bring to your attention how a really small team, they are a really small team, actually the work that they have done across our alliances and and our programs, our multidisciplinary programs around cancer, children, young people, mental health, etc. And the only way that they're able to deliver that is by working with partners. So, you know, we've called it PPI work, but actually it's very much work that has been delivered in collaboration with our voluntary sector, with our partner organisations, and not as a standalone PPI team. But I really think that we're going from strength to strength with our patient and public involvement, and I'm really hopeful that this strategy will put us into a good place for the next 3 years. So thank you.
Thanks, Lisa. I'll bring you in a moment, Fanuel. I think if the principle of co-production is met as the preferred methodology of developing service and improving services, then I don't think we can get a higher partnership level of working with patients and public. So I fully accept that when you're looking at the impact of a strategy into year 3, of course, it's going to look foggy. And it's good that it looks foggy, because actually it demands that we then work together to make sure that the intention of the strategy is delivered, and that the outcomes we get at the end will be good as a consequence. A far too well developed, detailed plan just goes down the pan as soon as we started, and risks people not being committed to the continuous quality improvement, just the dogma that comes in a plan. So I much prefer a strategy that does give a bit of a foggy look into the future, because it demands our attention on it. Fanuel.
Thank you, Lisa. I think we can see, particularly from section 2 of the report, how comprehensive, the engagement has been, and I think we do acknowledge how, the small team has really sort of worked right across the system to try and sort of get everyone to buy in. So, I mean, as part of the transformation, it does present an opportunity, for us to get people's voices from a wider area than we were able to do on our own. And you mentioned voluntary sector and other partners in there. But that also comes with a bit of a challenge, in the sense that we might not have the ability to influence as much as because that's all we can do. I mean, in the areas that we commission, we can evidence what changes are happening to the services as a result of what people are saying, because essentially when our communities come forward and tell us what the challenges are, what they want to see is how have you responded to that. Now, when the response is sitting outside of us in terms of the system, I think the challenge for us is how we are going to influence those partners to respond to the issues that have been raised, so that the next time we go to people and we talk to them, we can also say, you say these things, and as a system, this is how we've responded. So it presents an opportunity, but also a challenge in terms of the influence bit.
Thanks, Fanuel. And, again, if, coming back to that co-production bit, lots of small teams in lots of public sector organizations could be a really decent sized team for the public sector. And I think we need to think about how do we turn it on its head. So co-production isn't something that is done by service providers and commissioners with patients, but demanded by patients and our public of service providers and commissioners, and take it essentially to a different level as a consequence. And I look forward to meeting that challenge in the future. Dean.
Yes, and just quickly, we need to ensure that it isn't just a fashionable buzzword, that we align our financial, cultural and leadership strategies sort of around that, and that its full PDSA co-production, not just a 6-monthly photo op where we invite people with lived experience sort of in, because they do add an enormous amount of value to our pathways and our system.
Thank you. So I've got no other hands up. I think we're happy to receive and note that report, the 2 sections, Lisa, and some maybe some challenges for us to work in co-production to solve around how we take it to those next levels. So thank you for everything that small team is doing. We look forward to supporting them in the future. So shall we go to item 12, emergency preparedness, resilience and response? Paul.
Yes, thank you, Chair. By way of context, an area we probably don't spend much time discussing at any particular point, but we are of course all duty bound by the Emergency Preparedness, Resilience and Response framework. And whilst there aren't any immediate performance sanctions for pass or fail, I think we have to remember that it is underpinned by Civil Contingency Act 2004, NHS Act 2006 and the NHS Constitution. So whilst that would only be tested in the event of something happening, actually that particular framework is really important to ensure that ourselves and partner organisations are compliant. So as part of being a Category 2 responder as a CCG, we are duty bound to support NHSE colleagues in that assessment, and essentially it's what this paper actually sets out. So back toward the back end of last July, I was written to as the accountable emergency officer for the CCG as to what the process needed to look like for this year. And it's fair to say that given the COVID sort of pandemic situation we're in, it's slightly lighter touch than it would normally be. So essentially it was a self-assessment by providers, self-assessment by ourselves, a meeting with each of the providers to go through the evidence that there was, and then that was then presented to NHS England, and the conversation took place in terms of that particular piece of the assurance. So you will see in Table 1 that firstly the bar for full compliance is quite high, i.e. nothing less than 100% will do. Even 99% is not fully compliant, and you'll see that a non-compliance is below 76%. There's probably 3 areas to sort of pick out, I suppose, from the table. Great news in the sense that CCG is, significantly compliant, and essentially is only missing on one small element, which is actually the wider mutual aid, and by that I mean the involvement of the army or fire services and what have you. And that was really felt essentially because there needs to be a slightly more streamlined process to try and involve those folks if in the event of an incident. So again, really good news story in that sense. Great to see PPG is fully compliant, which is fantastic news. And the fact that the vast majority of our other services are significantly compliant is also a great success story. But you can't sort of miss the fact that ESEC is essentially non-compliant. There's a couple of reasons for that. One is a number of sort of core standards were slightly reduced. So again, the denominator dropped slightly and has moved them into the non-compliance route. And the only assurance that I can give is about 69% of all the core elements are fully compliant, and the remainder are partially compliant. And the team who've been working are pretty confident that can be rectified fairly quickly, and those conversations are taking place. And as I said, NHSE have gone through our evidence and have supported our assessment of it as we move forward. So essentially, I'll stop there. I think we are in a good place. Still a bit of work to be done, but again, great to see that level of assurance.
Thank you, Paul, and thanks to everyone in those services and in the CCG team to keep a close eye on all of these things. Any questions for Paul from that? Okay, so thank you very much. We'll receive and note that. I'm aware that we're about 5 or 6 minutes ahead of time. We haven't got a break scheduled in the agenda, so I wonder if people would appreciate starting at 11 o'clock again and taking a a break now. So we'll restart with the month 7 to 12 plan in the finance, performance and scrutiny section. So we'll meet up again then.
Can I just remind everyone that the recording will continue, so
just turn off your mics and your video and we'll reconvene at 11. Thank you. Okay, so hopefully we're all back. All lights coming on. Okay, in which case, shall we make us start with item 13, Jane, H2.
Yes, thank you, Chair. So, yes, apologies for the term H2. We've got rather used to, in this financial year, dealing with H1 and H2, a financial year of two halves. It's been spoken about earlier on the agenda that we have, that we've received our allocations and our instructions, if you like, our planning guidance for the first half of the year, and the board governing body considered that back in at an earlier meeting. We're now bringing the plans for the second half of the year that started on the 1st of October for your approval today, alongside the winter plan, which is not part of that formal planning submission to NHS England, but is obviously an important document that we wanted to bring to the governing body. So myself and other director colleagues are going to run you through the various elements of the paper. We will take it that you have read the detail, or indeed a lot of this detail has been through other committees, including the budget, which has been through the finance committee. So you'll be pleased to know I'm not going to go into every detail, but the covering paper basically sets out the ask, which planning guidance came out just right at the end of H1, so on the very last day of September, giving us the allocations and the very few, in reality, changes which were expected around what we're to deliver in the second half of the year. So in effect, this is to some extent a bit of a formality, because it really just builds on the work that we were doing in the first part of the year. But you hopefully you'll have seen in the guidance there's a link to the actual planning guidance that came out from NHS England and Improvement, and the 6 national priorities, which won't come as any major surprise to people, around staff wellbeing, vaccination programme, both delivering on elective care and emergency care, expanding access to primary care, and working collaboratively across the system, which obviously within Suffolk and North East Essex we already do a lot of. So the plan does incorporate both elements which are where we are as individual CCGs, or the 3 CCGs across Suffolk and North East Essex working together, but also where we act as the coordinator across the system as we move into being the formal ICS. You'll see, particularly in the financial plan, elements where we are pulling together the financial plans across the whole system. But I'll leave it there and I'll hand over to my exec colleagues. I think Richard's going to go first and talk about the plan narrative.
Thank you, Jane. So won't say too much, because a lot of this, as Jane said, is covered within the paper, and it's a further iteration on the first 6 months of the financial year. Just to give the board some assurance, we've got a weekly planning group that Paul, Jane, Amanda and I are part of with other teams, that's overseeing the ongoing never-ending development of our planning cycle. We're expecting also next year's planning to hit us on Christmas Eve, so we're going to keep the group stood up, so to speak, but may reduce its frequency just to keep an eye on what else is coming out of NHS England. I think Jane's put it well in terms of the 6 priorities. They remain the case. They've narrowed it down. This is section 4. They've narrowed it down to 4 specific elements that they wanted more of a narrative update on against our first 6-month plan, which is continuing the focus on the health and wellbeing of staff and taking action on recruitment and retention, which Amanda and Giles is doing a sterling job of across the system. We've got restoring full operation of cancer services, which myself, Narendra and others are working on through the ICS Cancer Board. We've got restoring increasing access to primary care, which Maddie and colleagues are leading within Ipswich and East. And then we've got transforming community services, which we covered in part with the Ageing Well paper earlier on in the agenda, and the winter plan that Paul talked to earlier. So I'm not intending to go through the narrative, it's more of an update. And as Jane said, we've seen a lot of the content of the various supporting boards and committees for the governing body, but at the end, happy to take any questions. And I'm now passing over smoothly to Paul for activity and performance planning.
Oh, I think I was doing winter plan, Richard, but I'm happy to do that. Just to touch base a bit on the winter plan, if I may. I think Mark, you eloquently gave an introduction at the beginning of this governing body in terms of the pressures being felt, and I think it's probably just worth reiterating some key elements. So, COVID and flu will play a major part in our winter this year. We've heard already the commitment to try and make sure we vaccinate our folks to make sure we avert any of those pressures. But it's fair to accept that we still have a fair number of patients with COVID positive admitted patient in our system at the moment. And whilst the numbers are marginally reducing, they are causing some operational difficulties in terms of the patient flow. So again, I think we have to acknowledge some of the difficulty and challenges. And of course, we don't know which way flu is going to go in terms of pressures at the moment. So some unpredictability there. Workforce may keep being a major feature, whether you're talking of primary care or secondary care or other services. A lot of services are doing more, maintaining what they were doing in COVID and recovering services. So again, we have to acknowledge the pressure that is actually on workforce. And you'll notice as part of the winter plan, there is quite a hefty section on workforce and supporting our workforce. Rising activity demand, key features, and essentially a return to elective recovery program. So again, a real sort of almost perfect storm of pressures at a time when actually we know seasonally the system ends up under a lot of pressure. So essentially winter planning or seasonal planning is incredibly important. And we will have approached it in the way we normally do in SNE. We look at our intelligence, we look at a coordinated approach, and behind each of those areas are detailed plans, quite extensive plans from each of our partner organizations. Ranging from mission avoidance, demand capacity modelling, increased resources to community, and working collaboratively with our local authorities, social care colleagues in terms of trying to improve domestic care market and community bed capacity and providing alternative offers. So I think that was sort of essentially tested with our regional colleagues, and I think it's fair to say that whilst there is a really high level of anxiety for this winter, and we shouldn't ignore the difficulties and the fact that we've been on level 3 for several weeks now, compared to other systems, we've been on level 4. There is a fairly high level of assurance from our regional colleagues in terms of our level of preparedness for this winter. Having said that, I think it's going to be an incredibly difficult winter, and we are continuing to plan and to other actions we might be able to take to mitigate some of the identified risks. So essentially, that's winter planning. Some of the details is actually included in the pack. I'm happy to pause there for any question, or I can go on a little bit about activity and performance.
Thank you. We've got Lorna's got a hand up.
On page 225 of 533 pages, it's got a graph, it's a bit like War and Peace, a graph of workforce recruitment and retention. And the only group, well, there are two groups that seem to be going up in terms of numbers. One is the infrastructure and non-clinical support, and I wonder whether you could comment on that, and nursing and midwifery. So it's good to see that those numbers are going up. But it's very disappointing to see that the support to clinical staff has come down. And really, you know, there's a lot about workforce support and well-being, but it needs to be felt on the ground for the people on the front line. And it doesn't matter if we don't want our providers to have a sort of empty rhetoric to all this, and that it must be felt on the front line that people are being properly supported. And so I'm concerned that I'm seeing infrastructure and non-clinical support going up. So I would like that explained, really. I don't know whether you know anything about that, Paul.
I think I'll comment. Maybe if Amanda's on the call, she might want to comment. But there is an extensive sort of people plan board and program to support our staff, and we keep it clearly monitored as we move forward. Amanda, did you want to comment on that part of the conversation?
Yeah. Thank you very much, Paul, and thank you, Lorna, for your helpful challenge. It is something that we are dealing with and continue to deal with at system level across Suffolk and North East Essex. And as you can imagine, is high on the people board agenda. We have no magic solution, but we are working tirelessly with the various groups that we have now in place across the system and through the Health and Wellbeing Collaborative to ensure that much needed support at ground level is very much there and in place for all staff. So it's something, Lorna, we are aware of and that we are working tirelessly to improve, but very happy to bring perhaps a more detailed update to the next governing body.
Thank you.
If I may come back on that, Lorna, just give some assurance. I don't think I'm involved in any operational conversation or any plans where workforce isn't mentioned, the way we support our workforce and test whether it is feasible or doable or even sustainable. So absolutely accept this is really, really challenging. But again, I think it's pretty much on everybody's agenda at the moment.
Having been on the ground, you know, one of the things, so for example, just as an example, there's an elective list, very, very busy list, too busy. So, and you do it because you feel you run late, you go through lunch, you don't stop for lunch, you don't stop for coffee, you don't stop for tea because you don't want to cancel a patient at the other end. But it means that the person above you who has put that list in has not thought about your well-being at all. And then you get a little thing at the end saying, do you want to go and see someone about your mental state? Well, I'm sorry, you've got to provide a working environment that supports the staff on the front line, whether that means more clinicians on the front line to enable people to get their breaks, or whether it means not setting unrealistic targets and not thinking about the actual process on the ground when you do something. So everybody is an individual, you know, we're not a number, and people need to, the providers need to think about that when they're producing these sorts of things. So when people leave the trust, leave our providers, there should be an exit interview, and it shouldn't be done by their immediate manager. It needs to be done by someone independent so that you actually can get some valuable feedback about what's gone on rather than trying to pay lip service to it. Anyway, this is the sort of things that Amanda and Paul, you need to drill right down to our providers to ask them, what are they really doing on the ground to make it better for the individual, and not just whether they're going to, you know, organise a fun run. Thank you.
Thank you, Lorna. Ed, and then Ayesha.
Yeah, I mean, really helpful challenge and insight from Lorna. I know that when we had our review meeting with NHS England, they said that healthcare support workers was an issue across the region, probably wider. So I think Lorna's right. We need to really raise that priority group, forward. And domiciliary care was the other one I think that we were kind of worried about. But you know, there are success stories too, as we said about nursing and midwifery. So we balance it off. But healthcare support workers, I think, have been overlooked, and there's much more we could do.
Aisha?
Thank you, Mark, and thank you, Lorna. I think you raised a very important point, and just with my Health Education England hat on, we've started working very closely with Francesca Crawley, who is the workforce lead across SNE, and Kate Reed, who's SNF lead for Peoples, and Amanda, and hopefully we will be working on things to make sure that everyone is treated with respect and has that, you know, as a human, you know, the clinics are not full. There is a break, there is respect and well-being support. And I think not only for primary care, but also for secondary care. And we're working together this time, and hopefully we'll see the results very soon. Thank you for bringing that in.
Thanks, Graham.
Yeah, thanks, Mark. I don't know if this is helpful or not, but I had my, I go twice a year with NHS England as an audit chair. And in the March meeting, they were saying for elective recovery, they were looking to put 90% on a block contract and have 10% of elective activity based on activity. But what they're actually saying now, when I went last week or the week before, they're saying they're really going to try and push elective recovery, and it's going to be 50%. They're calling it block contract again now, 50% block, and the other 50% is going to be based on activity. So what Laura was saying about, you know, people putting the list together for the elective operations, I think there's going to be a lot more pressure coming down that stream, because they're saying we're going to have to work at 125 to 130%. So it's just, you know, sort of saying, I think there's going to be more pressure coming, and sort of the team's welfare is going to even be more important.
I refer the honourable gentleman to the answer I gave at the start of the meeting.
I know, it's just that's the route they're going down at the moment.
I refer them to the answer I gave at the start of the meeting.
Yeah.
If they don't have anybody to do it at the end, Where will we be then?
Yeah.
You know, a reality check, please. Let's have the reality check. Where those decisions are being made, where is the reality check? Paul, do you want to come back?
Yeah, if I can come back to that, Graham, I don't profess to have a crystal ball in the current thinking of some of our NHSE colleagues, but what I would say is, and I'm looking to Jen to nod, I get it in the right places, but if you look at the ERF as incentivization process, if you want, for H2, it's been quite heavily watered down in the sense that it is much more difficult now to income any further monies into the system and the way the technical changes have been made. So if you're talking about incentivization for trusts to do more work because they get more money, that is far less in H2 than it was in H1, to the point where we're not quite sure even we'll income any additional income this in H2.
Yeah. I mean, we did sort of push back and say, is that realistic? Because I mean, they're even talking about efficiency gains, and we're saying, you know, while we're in COVID and everyone's got to mask up, take all the additional measures between patients and that, it's almost impossible to deliver, you know, I mean, real genuine efficiency unless you can sort of really change the pathway sort of thing. So I mean, we did try and kick back, but I think they're just getting so much pressure from the department that I think, you know, I'm just saying, be prepared, because I think we're going to be pushed quite hard on elective recovery. Yeah.
Yeah, and again, I come back, you know, to what I said at the start. I'm sorry, but just saying to do more is not realistic. It's not good enough. It adds to people's distress. It adds to the burnout. So, you know, we're constantly asked to be creative.
Yeah.
We're incredibly creative. What I ask is that those people at the senior decision-making level who are pushing these policies be creative.
Yeah.
Paul.
So this is probably, Graham, a good segue into some of the bit around activities. So and performance. In terms of elective performance and activities, there's probably sort of 4 asks, if you want, that is part of that plan. One is to maintain urgent elective activities, so what's called P1, P2, the most urgent elective activity. Recover cancer performance by the end of March. Reduce significantly the number of patients that are actually 104-week waits. And you'll see in our planning, we've not been heroic, we've been realistic into what we think we can achieve. So you'll still see a figure of roughly about 259 patients that we don't think we'll be able to clear by the end of March, whilst other systems have actually predicted 0, which is ambitious, to say the least, given, but doesn't mean we want to go further. Of course, we'll go further if we can. And then finally, an ask around maintaining current over 52-week wait patients, and an ask to try and contain the waiting list. So for H2, that is essentially the ask in terms of our planning. But I think you're right. I think come next year, I think there'll be conversation about how can we go further and faster. Will be the conversation, but we wait planning guidance for that on that basis. So essentially, what you've got in your elective performance is essentially a translation of all the narrative into what that means in terms of numbers and activity. That came through the strongly through from our providers. They were checked and cross-checked with NHG colleagues and challenged and refined as part of a process. And as you see, there's pages and pages of data there. I'm sure if there was any particular area you want to take us and look at, happy to do so.
Thank you, Paul. Lorna.
I don't know, we got to page 337 there. I was a little bit shocked about how bad our obesity problem was in the region. It's like 40% worse than the rest of the UK. And maybe I've got ahead of myself, have I? No, I haven't. So I think that is something that we really need to look at, because that is driving a lot of costs into the healthcare system. You know, we've had a patient story about someone who's had problems with that, and I think that we know it's linked to a lot of pile of comorbidity. So I think that we really need to work a bit harder at that for our population if we can. It's a very difficult problem. I absolutely appreciate that, but I don't think that that should be lost in the grand focus. I think as a board, we have an opportunity to look down on things and look at these big figures and say, you know, where should we be putting some extra resource? Sorry, Jane. I think that we need to look at that a bit more. It might get, we don't want things get lost in the ICS. You know, this is a...
Yeah, there's a very strong correlation, Lorna, with deprivation. And there's a very strong correlation for this region of coastal deprivation and the impact on inequalities and the demands on our healthcare services as a consequence, which is why I've raised it at the start. So yeah, yes, it is one of the key factors we've got looking forward in terms of the expected demand that will come if we don't address it. Similarly, the issue of the demographic demand as our population grows older. You know, there are things that we can prepare for, but not just in terms of meeting the demand, but in what we need to do to reduce it, which is why looking at those two key ingredients upstream, workforce capacity and deprivation, are going to be absolutely essential. If not, you know, it's not going to be good enough for this winter, but for every subsequent winter and for the next 2.5, 3 decades where we know that baby boom generation is going to go through, we're going to need it. It's not a 5-year plan, we need a 25-year plan.
I want to push back a little bit on that, Mark. I agree that we've got a very deprived population. I absolutely agree on that. But there have been more commentators now saying that actually we need more education, because people who are deprived and haven't got enough money, it doesn't mean de facto that they will be obese. So, and we need to try to get into that link. And I can see there are programs to educate young mothers and all this sort of right from the beginning. And that's probably where there would be worthwhile investment, is to take the people who are not educated and try and give them some information, both within the schools, obviously, everywhere this needs to be done. But I'm not as negative about it as you are. I think that we can make an impact with that in the food industry. I think we can try and move things forward. And I think perhaps we should be...
I'm on the same page with you, Lorna. The childhood obesity increase over the pandemic 18 months has been quite significant. And there's much that can be done through giving children a good start in life that can look at addressing that. But, you know, there is a correlation to deprivation. It's not the causation necessarily, but we have to ask the questions about what is it that will make the difference. If we're not asking those questions, we're not going to find out the real answer, and we won't make any change happen. Lolly.
I'm sorry, I can't turn on my camera because my signal is very weak, but just following on from what Lorna was saying and actually pulling from what we were talking about earlier with co-production, I don't think it's just a matter of education, because I think if any generation is educated or has access to information more than any other generations before, this is this generation. We've got people who have so much information. They know what to do. Most people know what to do. It's about enabling people to make the changes. And, you know, it's why having, you know, although not as many PCNs have taken them up, but having people like health coaches.
Hello, Luke.
Am I still here?
Your
Can you hear me?
Yeah, your microphone isn't working very well, or the signal isn't strong enough. Can you have another go?
Yeah, I'll try again. If not, I'll type in the comments if I can't, in the chat if it doesn't work. But I was just saying that it's about enabling communities to take that information and apply to their lives in a way that is culturally and appropriate for them. So and people getting people alongside. Behavior change isn't just about having more information. It's about being able to be helped to apply that information to your life to make a difference. And I think it's that gap. I mean, it's the same what we notice as I as a GP notice when I tell people, oh yeah, your BMI is over, whatever, you need to do this, you need to do this, you need to do that. Well, here's the information, here's a leaflet, off you go. Why doesn't it change by the next time I see them a year later? Because that isn't, information is not what more they need. So it's about, I think, going back to co-production, I think it's really important that we're working with communities. Okay, here's the information, but how can we help you? How can I help, this community to apply that information in a way that is, a way that makes sense for them? In a way, what can we, yes, we can commission big programs like One Life Suffolk and all the things that we've put out there, and they're great. But if they're not being accessed by those who need them most, what is it that we can do differently? What can we work with the communities to develop that actually will help them make a difference to their long-term health and really get on that prevention bandwagon earlier, not waiting until they're sort of, okay, oh, well, the diabetes level is really high in this deprived population 10 years from now. Well, we could see that coming. So that, I think, really needs just framing it differently, not so much throwing more education and commissioning more big services, but thinking about how communities can do it, work with communities to think about how it will help them.
Yeah. Okay, thank you. A rich discussion. Who knew it would be triggered by a winter plan? So, Jane, did you want to come in?
Yes, please. Well, if we finish that part, I would just like to do the budget aspect, but I didn't want to come in too early, sorry.
Yeah, no, by all means, come in now.
Thank you. So, just to conclude the paper, the final element that we're presenting today is the financial plan and the budget for the second half of the year. There's an appendix in the paper which is broken into two parts. Firstly, talks about the kind of overall scenario and the system, and then the second bit is about Ipswich and East Suffolk CCG specifically. The slide on page 196 of a rather long pack really sets out the main things in the H2, the second half of the year allocation. It hasn't changed hugely from the first half of the year. It's effectively a rollover of the envelopes that were received in the first part of the year. However, they have been adjusted for the pay award, which is good news. There's some additional funding for urgent care capacity, which we've treated as winter monies in our system, but with some reductions of the overall system funding for COVID, and there's been an increased efficiency requirement. Pleased to say that the hospital discharge programme continues, but there has been a really clear signal that that will end on the 31st of March 22. So we will need to work, as we work through our planning for 22-23, how we pick up the costs and try to embed the system change that brought about without the additional funding that's been available for that. We've already spoken about ERF, as Paul said, the hurdles to achieve it have been made harder for H2. So we are expecting that whilst that elective recovery, that additional funding for doing the elective work still exists, it will be much harder to achieve, and the plans that have been put in across the system don't assume a very large amount at all compared with what we've achieved in the first part of the year. Our block contracts with our providers continue, including a small amount of inflation and the back pay for the pay award. And overall, the systems were expected. We submitted a single plan for the system with the expectation that each organisation would put in a balanced plan for the full year, i.e. that the second half would be in balance on top of a first half that was already in balance. So we have achieved that across the system overall, apart from our the East of England Ambulance Trust, which is we host that on behalf of the East of England region. They have submitted a plan that is not in balance at the moment, but they are working hard with region to work through how that will be afforded for the remainder of the year. But I'm pleased to say that our system organisations have all submitted balanced plans. There's an awful lot of detail in the paper, which I'm not going to go through, about the allocations that we received. As you'll see, the first one talks about the monies that we received for the second half, which are, when you add them together, we received 1.8 billion across our system for the full year. It's I have to kind of take a little bit of a breath when I say that amount of money. We are charged with a very significant amount of taxpayers' resources that we are spending within our overall patch. That excludes social care, that's the NHS element. The second half of the year, when you add in all the extras and take out the reductions, is actually 6.6 million reduction compared with the first half of the year due to those reductions in COVID funding and the system efficiency. The next parts of the go through and talk about all of the assumptions that we've made using the national assumptions and the way that we've worked across the system to try and ensure that there are fair and equitable shares between the different organisations. So I'm not going to take you through the detail of that. The end of the paper is about Ipswich and East Suffolk CCG. Now, we've spoken at the governing body and certainly at the Finance Committee at length this year about the fact that finances have been incredibly tight for CCGs because of the way that the funding mechanism has worked during the COVID period, which were based on spend at a particular point in time. And did not give us any money to create the usual contingencies that we would put in place within the CCG. However, I'm really pleased to say that we have been able to build a balanced budget for Ipswich and East Suffolk for the second half of the year. The headlines on page 202 of the pack do go through the actions that we've needed to take around that, which are partly around some balance sheet releases and release of funds that we have previously worked with our partners on. But one of the main changes that has been agreed across the three CCGs is that Ipswich and East Suffolk will hold the COVID funding on behalf of the CCGs and will use that on a risk pooling basis. So with all of those actions in place, we do expect it to be quite tight for Ipswich and East Suffolk CCG for the remainder of the year. However, we believe that that with a fair wind and all the actions that we've got in place, that we should be able to bring that in financial balance. So I will be asking in the recommendations if we can approve the budget, which is set out on page 205 of the pack, because that's a formal requirement of the governing body. But it really is just the detail of the remaining, how the spend will be allocated across the departments for the remainder of the year. So apologies that is quite detailed, but it is something formal that the governing body has to do. We have submitted the draft plan through to NHSEI. If there are any further requirements or changes that are expected for that, I would ask the governing body if you would delegate the responsibility for doing that to the Finance Committee, just because of the timing of the next governing body.
Thanks, Jane, and thanks for the succinctness, for the extent of the paper and the hard work of all the team going into this paper. Thank you. Imran.
Thank you, Mark. Thanks, Jane. Far better news than we were receiving at the end of H1 financially, so much better. Question, what, if any, are the main risks you're still seeing in there, and is there anything we need to be doing now to sort of try and mitigate any of those?
So, as you'll know from discussions that we've had at the Finance Committee, the majority of the money that's coming to the CCGs is being passed straight through to providers. So we are left with a fairly limited pot of budgets which are within our control, but the main ones are continuing healthcare and prescribing, where we are seeing the pressures. I think the main risk we've got is around the pressures on continuing healthcare as we go into winter. We have built in a fairly significant uplift in the budget for that. Partly that was funded through the H2 allocations, but partly that's just as we've got greater knowledge of the packages that are in place, etc. on that. But I think that's the main risk. As we kind of go through winter, they're just very variable in terms of a few very high cost packages can be approved and it can swing things quite a long way. So we working very closely with nursing directorates and CHC team to keep on top of that. And as I say, hopefully we've allowed enough within the budget that we should be okay, but it is probably the main risk area for us for the end of the year.
So Mark, can I ask a supplementary just a bit around the CHC? Have we got any data or intel around the impact that D2A is having, particularly on CHC, and whether there's some work to be done around the discharge to assess work?
So other colleagues may have a better answer than this, but my straightforward answer is no, Imran, but I think that's definitely worth doing some work on, as we can see where things, how things compare on the CHC side. But I don't know whether Lisa, Richard is coming in on this.
Just briefly, so Paul Little, as our Area Director for Adult Social Care and Community Health Services, commissioned Attain, who is an external organisation, to do a piece of work which they reported last week through to the Discharge and Assess Board, which looked at the current discharge to assess model, how it's working, and what improvements might need to be made or could be made. So I wasn't at the board, but I'm catching up with one of the team who was there. I don't know if you were there yourself, Imran, but effectively there's quite a bit of work that's going to come out of that, which I can't remember the detail if one of them is continuing healthcare, but it would be that piece of work and that board that could, I think, pick up that further. But I think it's a helpful suggestion, Imran, in terms of an area given the challenge we've currently got on spend for CHC.
Thank you. So with those things in mind, are we happy to approve the reports and the budget specifically that we've seen? Yep. Okay. Approval noted. Thank you. So shall we move into the integrated performance report? I'll hand over to Paul to start that, and other directors to come in, just bearing in mind that we've had perhaps a richer discussion about the 7 to 12 months H2 plans than we were maybe expecting.
Thank you, Mark. Actually, few of the things I wanted to touch on the report we've sort of covered in terms of the winter plan and other things, but just to say a few things. Needless to say that the focus in the last couple of months has been really remained focused on urgent care, winter planning, and elective recovery, which actually has some direct bearing in terms of performance. As Ed has alluded to already in his opening remarks, you know, we've been identified one of the top 4 performers in terms of the level of activity that actually we are delivering. That shouldn't be conflated with the threshold of 120%, which is a financial threshold, not an activity threshold. So when we talk about actual activity, we shouldn't conflate those two, because they mean two very different things. And again, that sort of plays into the workforce conversation and the pressure in the system. I won't repeat the challenges in terms of elective activity around the focus on 104 weeks, etc. But what I would say is that we know which specialties are our greatest challenge, and those are orthopedics and gynecology and oral maxillofacial surgery. And essentially, it's compounded by the fact that we have a structural challenge at West Suffolk. And as you know, we lost 50% of our theatre capacity. And essentially, what we stand to see is a growth in inequity between the two sides. So that is really leading to a lot of very positive work, I would suggest, around mutual aid. And already we are seeing an orthopedic surgeon going over to Ipswich and so operating on their patients in that environment to try and close the gap. There's a real clinical dialogue emerging to try and make sure that we reduce inequities, improve performance, deal with our longest waiting patients. And we can see that happening across gynecology, around ophthalmology, around dermatology, around ENT. So some real positive work in terms of system working to try and address some of those waiting list issues, and by default the RTT performance as we move forward. I think it's got to be recognised that recovery of RTT is going to be a long-term plan. Hence, once there is now an active conversation starting around what our long-term elective recovery plan might need to look like, and how that links into the future performance, etc. But for the other specialties that I haven't mentioned, you know, we don't have any 104-week wait. The waiting lists are reducing. Some really positive sort of changes are happening in terms of the shape of the waiting list. Having said all of that, our waiting list is still growing, which you would expect we try to simply containing, and our level of over 52 weeks is slightly creeping, hence why we need the longer term strategy in how we address our elective recovery. In terms of where we are as a system, you have to balance emergency versus elective activity. And if you look at the latest figures in October, our elective activities dipped down in terms of what we've been able to deliver to about 78 or 80% compared to 85% was. That's a direct result of pressures, meaning leading to some cancelling of elective activity. But the good news, we're able to recover quite quickly within a couple of weeks by taking remedial action. So all that really has an impact on performance as we move forward. In terms of urgent care, we've really sort of touched on that as part of the winter plan. But what I would say is of particular concern, I think that's a regional concern, is around ambulance delays. and we've actually been written formally as a system and other system in terms of what we need to do to try and minimise any ambulance delays at front door, because those lead to, I think, Mark, as your introduction come out around, incidents happening on the back of ambulances, etc. So the system is working really hard to minimise some of that, employing every possible action that we can do to do that. It's fair to say that as a system, we're doing faring better than other systems in terms of delays, but one delay too many. So the system is actually working very, very, very hard to try and address some of those issues. So all the things that affect the front door performance, and what front door performance isn't where it should be, we are in comparative terms doing a lot better than other systems generally. That is not to say this is not going to be incredibly difficult winter and an incredibly difficult period that we're actually going through at the moment. So I'll stop there. I'll stop there. Really, there are clearly other elements people might want to pick up as part of the performance, which I think myself and colleagues be happy to answer.
Thank you, Paul. I think just reflecting what we've been, it's just been the conversation through the governing body meeting to date, isn't it? It's the reality of what's happening out there. So thank you. Any specific questions for Paul? In which case, Lisa, shall we talk quality?
Thank you. So I'm going to step away from tradition and not go through each provider, because I think I would probably be saying similar things about each provider, and I think we've had a good discussion. You've already covered the quality bit, all of you guys. So the biggest risks to quality that we have in our providers and is around workforce and demand, and that relationship between both. So my colleagues in providers tell me that the demands on staff and the inability to meet patients' needs, both through our ambulance trust, our mental health providers, our acute trusts, and the emotional labour that has on staff, impacts on retention, impacts on sickness, and impacts on our workforce numbers, and that ultimately impacts on patient experience and patient outcomes. And we have seen an increase in serious incidents across the ICS, across all providers. We've seen an increase in incidents relating sometimes very directly to delays in treatment and care. Sometimes it's not so easy to map the consequence and the impact to the root cause. I think providers are working incredibly hard on the psychological safety of their workforce, but it's really difficult to hold their workforce without tackling the root cause of it, and it has the potential to become a real spiraling effect that we've all talked about. There's a huge amount of work happening to support the workforce, but I agree with your comments and Lorna's comments about we need to be compassionate leaders to our workforce. We need to make sure that our workforce are supported and not too much is asked for them, because if we know there's significant links with staff experience and patient experience, and I think that's the biggest quality risk we have in a system. Thank you.
Thanks, Lisa. Anyone wanting to ask any questions? I think again, it's just demonstration of where the themes are taking us, really, isn't it? And we've got to start looking upstream, not just at what's happening at every single consequence. We've got to start thinking harder about what the upstream actions need to be. Richard, did you want to talk next?
Thanks, Mark. So this is from slide 404. So as colleagues have said, we've already covered quite a lot of ground on this, so I won't repeat the points in the transformation programs we've already covered. Just to pick out on the elective care transformation program, the work that Paul and I are sponsoring with others on musculoskeletal and eye care. So the work at ICS level is now going at pace. We've got the new groups formed, programs of work where added value is, from place level up to ICS is happening. A couple of bits just to point out on iCare, which is the group I'm chairing, is we've commissioned a piece of work to look at demand and capacity modelling longer term. So rather than looking at the here and now challenge we've got, we know particularly within iCare, it's an ever growing and significant level of demand across our services. So we're hoping to get a 5 or 10 year demand and capacity model that can actually future-proof us and look what else we need to do, particularly into our workforce profile over the coming years. So we'll report back through to the executive. We're hoping we'll get something as a first draft, probably in around February for that. Going on, we've already covered the integrated care programme through D2A, INTS, end of life, etc. So unless colleagues have got questions, I'll move on from there. Equally in children's, I covered off neuro and community paediatrics as part of the further item earlier. They're the major bits. Just on mental health, I'm conscious for once, we haven't actually spoken yet really around adult mental health. So some good news, I think for Ipswich and East, as of Q2, quarter two, we're at 50.7% for serious mental illness health checks. This is slide 420. I think we're highest, if not second highest in the region, which is great news for that point in the year to get to that key target for year end. And also just to point out again, and I know Suffolk Users Forum came to the governing body, I think, for when we did a patient story. The current pilot again is going from strength to strength in terms of the partnership that voluntary care and social enterprise organisation's got with NSFT around supporting those who've had a health check around their ongoing need to access ongoing services. Again, recruitment's going relatively well for the mental health adult practitioner posts. So in Ipswich and East, if you recall, there was 18 posts that we'd committed to fund. We're now up to all but 8 posts, so still 8 posts to recruit, but the others are either in post or have got a start date. Lots more work to do to embed them and retain them so they don't actually get overwhelmed in terms of the nature of the role. So more work to do around that. We're due to come back to the governing body at the end of January with the outputs of the assurance process from Paul and myself, of which many of you are involved in. So if you recall, that is effectively looking at the new commission model for mental health services, which will start probably from 1st of April when the ICB forms. And also we're about to go out to procurement any day now for the crisis safe havens and community hubs for Suffolk, and also the Connect model that we commissioned temporarily from Suffolk Mind as a pilot. We're also due to go out on that. So that they will go out, plus the voluntary care framework that we've talked about before, hopefully in the next few days, which is great news. And then finally, just to finish on our wider strategic programmes, we've also got a piece of work underway around neuro rehabilitation. So an options paper about how we need to put ourselves on a firmer footing around that much needed part of our health services. And then finally on cancer, just to pick out a couple of headlines, we're launching a new community breast pain pathway at the end in November, probably in the next week, possibly early December. So that's been supported by Professor John Robertson, who's a leading light of cancer over in the East Midlands in Nottingham, who's has actually achieved 2-week wait for breast cancer throughout the whole COVID pandemic and onwards through effectively changing, not despite some challenges, changing the current model to pilot something quite different in a community-based provision. So if anyone's interested in that, more than happy to provide further details. We talked about it again at the ICS Cancer Board last week. And finally, we've got a patient co-production event, or either we've just had it or it's this week, can't remember the exact date, where we're looking to what more we can do to build our programme into next year with our really important service users who've been supporting us through the cancer programme. So that's just some highlights of the work underway.
Thank you, Richard. Any queries? So still capacity to do the transformation, which is great, and so much needed. Maddie, primary care?
Thank you. So very briefly, I was also going to mention LD health checks. He got there first. That is positive, and we just need to ensure the two things that Richard said: A, that we keep going, and secondly, that the quality of care that individuals have after their health check is also of an excellent standard. So that's a real focus. there's two different positions in the papers with regard to the SMI checks. It's just important to note, I think we will meet the targets, again, the same point about quality, but the way in which they're profiled naturally depends on, as for LD health check, it's the point in the previous year at which you had your health check, because they're an annual check. So I think they're progressing well. We're slightly below where we should be in terms of dementia diagnosis, and we need to ensure that that has sufficient attention and support. And prescribing, as Jane has alluded to, is significantly over budget at this point. There's multiple reasons for that related to the budget setting process and due to prescribing. I think that began during the COVID period, necessarily so. So we have some significant plans to address that position. The only other things I would like to say is, so there's a lot of work going on within practices to look at the model of care and to ensure that the access is a balanced access that responds clinically well to patient needs. And there are changes going on in some practices, and we're working to ensure that patient groups are working with those practices, or practices are working to ensure that as those changes are made. And I think that's very positive. So there's an increased move, for example, to use of a slightly different online platform that we think will be helpful both to patients and to clinicians. I think it's absolutely imperative that I too mention the strain that the workforce is under, and you will have seen in the press some of the real challenges that we have in Ipswich and East Suffolk in relation to GP numbers. The practices are doing brilliantly at working and leading multidisciplinary teams to ensure good care as we work to increase the number of GPs within the area. There are two other factors I think are important to note in terms of primary care. We're working very hard on data. We don't or haven't had to date the same flow of data, other than, for example, in prescribing, that exists in some other parts of the system. And we're very grateful to Suffolk Primary Care for working with us to provide a proxy as a minimum for the whole in terms of the volume of demand and capacity within primary care. And the last point to mention is that in addition to the workforce challenges related to the workforce challenges and to the increase in demand that we've seen in primary care, is an estates issue, which is really becoming quite acute. Because as we diversify the workforce and as the workforce grows to respond to demand, we're using every kind of method that we can with practices to ensure that space is available, but we are reaching absolute capacity in some areas. And I know that that's an issue that Amanda and her team and colleagues across the system are working really hard to address, but we will have to come back to that issue, I think, at some point, because the absolute challenge that we're facing. So I think it's just essential that I mention that alongside the workforce as a huge challenge within primary care.
Thank you, Maddie. And I mean, the estate isn't just about being able to see people face to face, it's about where people get trained. And we know that if we're doubling the numbers coming through our undergrad in University of Suffolk, one of the great places they could be training is in the community and seeing the real benefit of working in the community. And if we don't have the estate to do that and support it, it becomes a sort of catch-22 situation. So a really important one. So thank you, Maddie. Any questions about that? In which case, Jane, a little bit more on finance.
Thank you. Just really quickly, obviously there's a comment in the IPR pack about the fact that because of the pause as the plans go in, there isn't a month 7 report, but I just wanted to update the board on the month 6 report, which was in the draft on the IPR before I went away on holiday and seems to have disappeared. But anyway, it was just to let the board know that we did report a balanced position for Ipswich and East CCG at the end of month 6. That is after we will have received our top-ups for hospital discharge programme and elective recovery fund, but just so that the board is aware that we did achieve our break-even position.
Great, thank you. So any further questions? I haven't missed anyone out, have I? No? Great. In which case, shall we go to the Governing Body Assurance Framework? Graham, anything particular that you want to raise? I think we've discussed much of what's been within the framework, it being the dynamic thing that it is.
I've got nothing to add, really. I mean, just to sort of confirm what Lisa was saying, really. I mean, this is a lot of the GBAF is based around performance, you know, A&E, cancer targets, RTT, and that sort of thing. But I think what Lisa was saying about delivering safe services sort of now and going forward is going to, you know, obviously be one of our key priorities. And whether that'll have an effect on the GBAF and how, you know, the risks that are, how they're listed out in there possibly might change in the future. But it is all about safe services going forward, isn't it?
Indeed, thank you. Anyone got any comments about any of the GBAF? No, in which case we'll reviewed it, approved it, and we'll move into the declaration of interest paper. Amanda.
Thank you very much, Mark. So here is our updated declaration of interest for all governing body and executive and staff members, which we are obliged to publish on our website. So it's really here to note and encourage us to make sure that we have a full compliance as we move forward. So it's really a polite reminder as well for anybody that hasn't updated to update and ensure that JML has an updated record. Thank you, Chair.
Thank you, Amanda. And yes, notes to self if you need to make one. And Joe is ready and waiting to create any updates you want to put in. Thank you for that. So on to the health and safety update, Amanda.
Thank you very much. So here is our regular update, and as colleagues will see, the Health and Safety Group last met at the end of October, and really the ongoing issues continue to be focused around making sure that we have safe working environments by way of updating our risk assessments, which are duly updated and published. We also have a lot of conversation and discussion around home working, which is a key feature of our annual plan going forward. And with regards to home working, we're now ensuring that that's part of the ongoing work that we're doing through Lizzie Maplebeck and team around the CCG closure, and making sure that as we move forward, home working becomes safe and appropriate and reflects what we as an organisation want for our workforce as well. So really they were the key issues coming from the last meeting, but again, happy to take questions, Mark. Thank you.
Thank you, Amanda. Any queries? No, in which case, thank you for that, and happy to receive and note it. We've got the minutes of the meetings to receive. Anything from there, Graham, that you wanted to bring to attention? Doesn't look like it.
Well, I just say, Mark, at the last meeting we asked for the Alliance Committee meeting minutes to be presented, and that they're actually included within this. I know that Anthony Dooley had an interest in those, so I'm just basically saying the minutes are there for the Alliance.
Indeed they are, so thank you for that. In which case we've come to the end of business. We've got the date and time of the next governing body being the 25th of January 2022. Lorna, I've just noticed your hand go up.
Yeah, no, I just want 5 minutes. I'm sorry about that. One of the things that I think that we should be doing, and I think that we have a very important role, and not even though we're moving into the ICS, is that we've just had COP26, and of these 533 pages, we've not really talked about sustainability, and we must do it. I really feel that, you know, we're talking a lot about mental health. The fact that the planet might be on the brink of a disaster will have tremendous adverse effects on people's mental health right across the board. And I think that, and as well as pollution and malnutrition and all the things that, you know, that we care about for our population. And I think that we need to grasp this elephant in the room and say, right, of this £1 billion that our ICS is getting plus, we must have an impassioned sustainability champion who is going to make everybody within the system carbon literate and environmentally literate, and is going to take responsibility right down the line into every provider to make sure that they are doing their utmost, and that any procurement that we organise will also be judged on its sustainability. You know, the NHS is responsible for 5% of the carbon footprint in the UK. And I think that we have got to do our bit. And I think that the population are looking to the leaders to do something. We can't just carry on as we are. We must be seen to be, we must be seen. We must do something about trying to deal with this. And I think that that must go through to the ICS. And a person, it should assume that someone who is a sustainability champion or the leader of the system will be on the board and will be responsible for trying to reduce our carbon footprint and make us more sustainable. And, you know, I think it should be, just as we've had equality and diversity as a golden thread through everything, this must be a golden thread through everything we do. We've been very lucky in a way in that the pandemic has forced us as a group to go onto Teams and things like that. So we have, it wasn't from us saying we must do that. We were forced to do it. But, you know, we can change things. And I think that as a board, we must be pushing for this now. So sorry about that rant.
No. Thanks for the challenge, Amanda.
Thank you, Mark, and thank you, Laura. That was not a rant, but a really good, helpful reminder. And I'd just like to come back and confirm all the points that you have raised. We as a CCG and system are taking forward. We have a sustainability lead, Andrew Urquhart, who I believe has been at a fairly recent clinical executive. Andrew has recently presented to the ICS board the great work he and his colleagues are doing on the Green Plan agenda. And I think it would be really helpful that we invite Andrew to come to our next governing body meeting so he can share the great work that he and his system colleagues are doing to move this agenda forward. Thank you, Mark.
Thanks. So we can see what's happening, Lorna. I'm also aware we've got an air quality summit that's coming up for Ipswich and Suffolk. So looking at trying to tackle some of the immediate issues as well that not only affecting climate in the future, but are affecting people and their health directly as well.
So with the ICS, though, we need to demand that there's someone on the board for this. You know, this is the problem that the youth are worried about, is there's a lot of chat and it's not moving fast enough, you know. So I don't know what you think, Ed, but we need to really push this forward to make sure that it's in everything that we do, you know.
Yeah, I completely agree with you. We will have a board lead on the ICB, and it's going to be one of the central priorities. There's no doubt about it. The chair of the ICB, Will Pope, is, if you view his various honours and responsibilities, he's national lead on sustainability, and it's his big passion. So I think he'll bring that particular flavour to the board.
So
thanks.
Hopefully a recognition of what you're saying, Lorna, that you know, going forward, it's got to be a vitally important element of what we do. So we've come to time for questions. Joe, you've sent through some email requests. Have we received any others?
No, I think there's 7 questions altogether.
Okay, so I've got them. Shall I read them out and and then maybe ask people to respond or respond together. So as far as I'm aware, they're all from Anthony Dooley. And he says, I hope you're well. I'd like the following question to be posed at the meeting of the CCG today, please. What's the response of the CCG to the unprecedented protests in Ipswich and Bury on Sunday afternoon by midwives and midwifery students concerning safety issues? Lisa, did you want to open?
Thank you, Anthony, for your question and your continued interest in midwifery and maternity safety. So this was a national, it wasn't just in Ipswich and Bury, I just need to point that out. This was a national march that midwives took part in, and so I guess my response is I would always support the workforce to raise concerns. This was a march that was done outside of the RCM and our providers' support, but I would always want to listen to the workforce. And I think it just signifies, as we've said throughout this meeting, how worried our workforce are about safe services and being able to deliver safe care. We know, and we've talked a lot about maternity services and recruitment of midwives. There's a huge amount happening to attract international recruits into midwifery, to look at how we can encourage more people into midwifery, but none of it is a quick fix. So maternity remains an area of concern for us. And I support midwives in raising concerns.
Thank you, Lisa. Anyone else want to add anything in? I suppose again, it's a reflection of what we've been saying throughout the meeting, isn't it? It's about the impact of capacity on the ability to I was going to say deliver, I suppose that's the right word though, the safety elements, which you raised quite reasonably within the performance report, Lisa. Okay, next question. Mr. Javed has stated that thankfully there are low levels of deaths from coronavirus. Given that more than 1,000 people a week have been dying, do you share his view of low levels? Anyone want to pick that up?
I suppose any death is one too many, isn't it, Mark? So that's the right response to that. We benchmark and compare all the time in our jobs. The government do the same when they benchmark against other countries, but the bottom line is one death is one too many.
So next question, can you specify with criteria when the NHS would be overwhelmed? At present, it is a word without denotation.
We've got triggers in our winter plan, which Paul may want to point Anthony to.
Yeah, thank you. I won't begin to answer how the NHS per se declares that, but from a local perspective, the winter plan, and I won't read through them, identify all the trigger points we are continually monitoring and assessing on a daily basis. Part of the winter plan is to stop us from getting to that point. And the other thing I would say is that we're also clearly linking those triggers into our EPRR structures. So in the event that should we be overwhelmed, in inverted commas, i.e. cannot cope with the workload, the system comes together to decide what action are required at that moment in time. So we're well laid in plans. That is not to say we're not going to have a very difficult winter.
Thank you. Thanks, Paul. The next question, you've responded to the patient's story I sent you with the response that the experience was unacceptable. Are you not, at least in part, responsible for this and other unacceptable experiences? The frontline staff are not to blame. Who is?
So we don't have a blame a culture in Ipswich and East Suffolk. That's not how we operate, but we are accountable for the services commissioned, the majority of NHS services commissioned in Ipswich and East Suffolk. Anthony, so the accountability sits with this board, and specifically with me as accountable officer and Mark as chair. The specific case you were referring to is a poor experience in an emergency department at Ipswich. There's obviously accountability as the provider of services there too. So I hope that answers your question.
Thank you. Currently, 10% of the East of England ambulance crew are off sick, mainly due to stress and other mental health issues. How does that square with your remit to promote mentally healthy workplaces?
Amanda might want to come in here, but we're putting a lot of support within our system to support the mental health of all of our staff, but including the Ambulance Trust, and there's similar initiatives around the region. So we're absolutely committed to the mental health of our workforce. But Amanda.
Thank you, Ed. Indeed, we are. And just to build on what you've said, we are, as an organisation and as a system, working very closely with the ambulance service. And only last week, I, along with Health Education England, spent some time with their current HR director working through this very issue. And what we have agreed to continue with is the ongoing wraparound support that we are providing as a system and through the Health and Wellbeing Collaborative. So thank you very much for your question, Anthony, but please rest assured that we continue to do everything we can, working with our organisations, including the ambulance service. Thank you, Mark.
Lisa?
If I can just add to that, because I think it's it relates to something that I said during the performance report, and it's really difficult for EEs to resolve this on their own, because some of the issues that their staff are seeing relates to, as I said, the really difficult context that some of their staff, from call handlers to support workers to paramedics, and you know, there's a huge amount of work that's happening, and we absolutely need to wrap support around those staff. But it's a real system issue. This EE staff are kind of the victims at the end of it, really, in some ways. But we need to focus on the work that Paul was talking about around how we make sure that our patients are getting good care, so that staff feel that they are able to deliver good care and don't suffer well-being issues when they're unable to deliver good care.
Thanks, Lisa. Again, comes back to the introduction and a lot of the themes that have run through the governing body agenda today. The next question is, given the failure of Stuart Keeble's 3Cs, and Stuart is our Director of Public Health, in July that you endorsed, why have you supported his recent 5 asks of the public, given your understanding that, as Einstein said, to repeat an action expecting a different outcome is a sign of madness?
I suppose the way to answer that is we are supportive as a Suffolk community of all the work we've done through the pandemic. We're very proud of our response. Our particular focus, one of our particular focus has been on vaccination, where we've gone beyond national averages, and we've accelerated quicker than most areas of the country to protect people. And that's just one element of it, of an enormous response to the pandemic. So I don't agree with the assumption behind that question, which is suggesting we don't care about the people of Suffolk, or we're not protecting them as well as we can do.
Thank you. And a final one, will the CCG seek publicity for the statement by me at the beginning of today's meeting? Plus, will you send it to MPs within the CCG with an expectation of responses to the specific issues raised?
Well, I'd suggest this has been a public meeting. It's available online if people want to listen to your statement. They're absolutely able to do so.
Thank you. Okay, and we've not received anything else in the meantime, Joe, that you're aware of?
Not that I'm aware of, no.
Okay, in which case we can call an end to the meeting, and we'll meet again in public in January. And if everyone can jump on to the part 2 for the end. Do people want to do that now and